Total hip replacement is a surgical procedure in which the damaged cartilage and bone is removed from the hip joint and replaced with artificial components. Total hip replacement is performed in the operating room after you are given general or regional anesthesia. The surgical approach used will be determined by the surgeon and is typically a single incision along the posterior, lateral, or anterior aspect of the hip. Less invasive hip replacement surgery techniques, which use smaller incisions and specialized instruments, are often used. Hip anatomy overview: the thigh bone, femur, and the pelvis, acetabulum, join to form the hip joint. The hip joint is a ball and socket. The ball is the head of the femur or thigh bone, and the socket is the cup shaped acetabulum. The joint surface is covered by a smooth articular surface that allows pain free movement in the joint. The cartilage cushion the joint and allows the bones to move on each other with smooth movements. This cartilage does not show up in X ray, therefore, you can see a joint space between the femoral head and acetabular socket. The pelvis. The pelvis is a large, flattened, irregularly shaped bone, constricted in the center and expanded bone and below. It consists of three parts: the ilium, ischium, and pubis. The socket acetabulum is situated on the outer surface of the bone and joints to the head of the femur to form the hip joint. The femur. The femur is the largest bone in the skeleton. It joins to the pelvis acetabulum to form the hip joint. What are the indications of total knee arthroplasty? The hip arthritis is an inflammation of the joints resulting in pain, swelling, stiffness, and limited movement. Hip arthritis is a common cause of chronic hip pain and disability. The three most common types of arthritis that affect the hip bone are osteoarthritis. It is characterized by progressive wearing away of the cartilage of the joint as the protective cartilage wears down. The bone ends rub against each other and cause hip pain. Second is rheumatoid arthritis. This is an autoimmune disease in which the tissue lining the joint, synovium, becomes inflamed, resulting in the production of excessive joint fluid or synovium fluid. This leads to loss of cartilage causing pain and stiffness. The third is the traumatic arthritis. This is a type of arthritis resulting from a hip injury or fracture. Such injuries can damage the cartilage and cause hip pain and stiffness over a period of time. These are the information that the operating room personnel need to know and confirm. First is the site and the site of the fracture, left or right, or hipped, knee, arms, or in the head. The type of operation planned, the procedure name written in the consent, the type of anesthesia, if she will be given general or under spinal or epidural anesthesia. Ensure that the operative site has been marked by the surgeon. Implant to be used, the type of implants, the site if it is left and right, size availability, and expiry date. The positioning devices and the patient positioning should be ready. It should be determined if the patient will be in supine, anterior, lateral, or posterior approach. The details of the patient, including a signed consent form, an appropriate antibiotic, and thromboprophylaxis. Comorbidities, including allergies. These are the following instrumentations needed for total hip replacement. First is the major bone sets that comprises of instruments for tissue dissections, retractors like Hommans, sharp and blunt tip like cobra tip, right angle retractors, wide and narrow long-angled, rake retractors, Cobb's elevators, bone hook, sked elevators for the femoral head elevations, corkscrew extractions, mallets. Next is Charnley retractors to facilitate wide opening and wide exposure of the hip and acetabular bone. Third is power drills that comprises power handpieces, saw handpiece with saw attachment, reamer coupling attachment, AO drill, and keyword track couplings. Next is the femoral and acetabular reamer sets on different sizes from smallest to biggest. Hip replacement reconstruction sets from the company. Important items that should be ready and available inside the operating room such as bone cement, cement gun, pulse lavage, and hip implants in different sizes. For total hip implants, hip acetabular cup, polyethylene liner, femoral head, femoral stem. For bipolar hip implants, bipolar head, femoral stem. The patient will be placed in lateral decubitus. In lateral decubitus, the patient is placed with a hip to operate on the top. Adequate padding is then required with double support on the front for the superior iliac spine and back for the sacrum to keep the patient's position and sustain the body pelvis. The patient is supported in the lateral decubitus position on a radiolucent flat top operating table. Pad all bony prominences and neurovascular structures carefully. A gel roll should be placed under the mid portion of the chest to protect the axilla and allow for ventilation. Place the ipsilateral arm across the chest to be out of the way. Position the image intensifier on the opposite side of the injury and the operating surgeon. The surgeon makes an incision, usually at the side or back of the hip, cutting through the skin and then through muscles and other soft tissue to expose the bones at the hip joint. Then the surgeon will ask for a reciprocating saw to cut the head of the femur from the neck. The corkscrew will be used to remove the head of the femur. The surgeon dislocates the joint, removing the head of femur from its socket in the pelvis. The socket is called the acetabulum. The acetabulum will be exposed. Then the surgeon prepares the acetabulum for its acetabular cup prosthesis by using a special tool called a hemispheric acetabular reamer to grind down and shape the socket. The acetabular cup is placed into the reshaped socket. This cup is often made of porous titanium metal to allow the bone to grow into it over time, or it may be attached with special bone cement. The type of cup and how it is attached to the bone depends on the surgeon's preference and the patient's physiology. The surgeon puts a rounded acetabular insert or liner inside the acetabular cup. The insert may be ceramic or plastic and will facilitate smooth movement within the new joint. The surgeon prepares the femur bone by broaching and inserts the prosthetic femoral stem into it. The femoral stem is a narrow, tapered metal shaft that fits several inches down inside the femur. The top of the stem is designed to hold a prosthetic ball that will replace the femoral head. Then the surgeon will remove the trial components. After confirming correct size of hip stem, the final stem implant is applied and inserts the final ball into the new socket, checking again for ease of movement, potential ease of dislocation, and restoration of the proper anatomy of the hip, including the leg length. Then the x-rays may be taken to assure proper sizing and positioning of the components. The wound is closed and dressing applied. Post-op, the abduction pillow applied between legs to keep hips abducted.